You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from benchside to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, and today we are joined by ONS member Clara Beaver, clinical nurse specialist at Karmanos Cancer Institute in Detroit, Michigan, member of the ONS Metro Detroit Chapter, and Secretary-Treasurer for the Oncology Nursing Certification Corporation Board to discuss intravesicular chemotherapy. Thanks for joining me today, Clara.
Thanks for having me.
To start us off, can you describe what intravesicular chemotherapy is?
Sure. So intravesicular chemotherapy is when chemotherapy is installed into the patient's bladder via a catheter. The chemotherapy is left in the bladder for around 2 hours, and then the patient either urinates or the urine is removed via the catheter. So instead of giving it through an IV or through pill form, we're actually instilling it right into the bladder.
How does this differ from other chemotherapy treatments?
So this differs from other chemotherapy treatments in the way that the chemotherapy is exposed to the bladder. So instead of putting it in through the vein or taking it orally where it's brought in through the bloodstream to the tumor, this is actually instilled right into the bladder cavity, and it kind of sits inside the bladder cavity and adheres to the wall of the bladder. And so then it's absorbed that way instead of through blood, which then goes through, when we put it through the blood, it goes to the kidneys and is exposed to the body. This is really just affecting the cavity itself where the tumor is.
What process does this treatment entail? Do chemotherapy-competent RNs administer the intravesicular chemotherapy treatments in some practices?
So the process of giving intravesicular therapy really starts when the patient first comes in and we test their urine to make sure that they don't have a bladder infection or any hematuria in their bladder or in their urine. And that's really just to make sure that we are treating the actual cancer and not something else going on with the patient. Once the agent is ready for installation, we have the patient void, and then we insert a Foley catheter into the patient. Once the catheter is inserted, you can use two different ones, either a straight cath or a Foley cath with the bag attached. We use the one with the bag attached. We make sure the patient's bladder is empty, and what we do is we use the Coude method, where you kind of push on the bladder and push any of that urine that's hanging out in there out into the bag. Once the patient's bladder is empty, we clamp the catheter bag and hang that above the patient's bladder. And then we instill the medication via the specimen port on the Foley bag into the patient's bladder via gravity. It is recommended that chemo-competent nurses administer intravesicular therapy, but there are some practices where that's not the case. I've heard of urology offices where nurses that are not chemocompetent or physicians are instilling this. But again, we always recommend that a chemocompetent nurse is instilling this because, again, it is chemotherapy and there are safety protocols that we should follow with our patients.
Excellent. What additional competencies do those nurses need?
So obviously, we would love for them to have the chemo immunoprovider card or some type of chemotherapy education, whatever their institution provides to them. Really, the nurse needs to know how to insert a catheter. Again, we learned that in nursing school, but it's important to be able to know how to insert the catheter for the patient. And then really assessment of the patient before, after, and during the administration of the intravesicular therapy is very important. Knowing how to run a urinalysis could be important depending on how your institution does it. Some institutions send it to the lab, some do dip testing, some do where you look at it afterwards. But again, really assessment is key in these patients. And so just like any chemotherapy, ONS recommends that we use double chemo gloves, a chemotherapy gown. And really with this one, because there is a risk of splashing when you're putting anything into the bladder, you should wear a mask with a face shield when you're doing this. The other thing is that we recommend that you use a plastic back absorbent pad underneath the patient, because again, once there can be some leakage of the medication out of the patient as we're administering it. So that just kind of protects the bed and the patient's clothing.
What PPE would be required for this?
So again, the PPE required, just like most other chemotherapy agents that we administer, chemotherapy safe gown. double chemotherapy safe nitrile gloves or chemosafe gloves, and a mask with face protection is very important, again, because there is a risk of splashing or leaking with this administration.
Great. Should a closed system drug transfer device be used?
Yes, if possible, a closed system transfer device should be used. Unfortunately, there's not many on the market for intravesicular therapy. So that is why I actually developed a closed system for administering intravesicular therapy using a Foley catheter. ONS talks about the Washburn system, which is discussed in the ONS safe handling guidelines. But as it's stated with this system, there is a high chance of leaking and slippage of the syringe because you're actually inserting the syringe into the catheter. So by using any type of closed system that we can find works better for these patients.
That's really good to know. How should the bladder drainage be disposed of? Is there confusion that people have between the yellow and the black buckets and where things should be disposed of?
I get asked that question a lot. It is kind of difficult to understand because, again, we are administering chemo into the bladder of the patient, and then we're having them excrete that back out through the urine. And there is some concern whether that chemo agent is still active or not, or if it's diluted. But again, if it's anything over a trace, we should dispose of that in a black bucket. But again, you need to check with your institution and your waste handling guidelines. It's your organization because sometimes they are a little bit different. But anything over a trace should be disposed of in the black bucket. Anything trace should be disposed of in a yellow bucket. So when you think about if you take the system down after it's instilled into the patient and you're not taking their urine out after, that's trace waste. It's just a little bit is in the actual system that can go into the yellow bucket. But if you keep the catheter in the patient, dispose of the urine from the patient, that should go into the black bucket because it has active chemotherapy in it. Now, if the patient's voiding in a urinal or a bedside commode, it is recommended that you flush that safely like you would any other time, and then dispose of the urinal in the yellow bucket, and then clean the bedside commode, depending on whatever agent they receive. There's a couple different things that you would do for that.
Okay. What is the difference between Bacillus calmette-guerin, commonly referred to as BCG, and chemotherapy?
So BCG is used very commonly in bladder cancer. Actually, when you see intravesicular therapy given, it's usually BCG. There are a few other agents that we give, but typically we give BCG. And what BCG is, it's an inactivated form of tuberculosis bacteria. So again, that's a scary thing, right? Like, we're using TB, but again, it's an inactivated form. The reason we use that is it works against the cancer as a biologic response modifier. So basically, we're triggering the immune system to work for us against the tumor. So that's the difference between that and chemotherapy is it's, again, mostly like an immunotherapy instead of a chemotherapy agent.
Do nurses need to use safe handling precautions for both?
Yes, they need to use the exact same precautions for BCG as they do for chemotherapy because, again, we have seen in the past, before we started using some of these safety precautions, where nurses' TB tests would actually turn over to positive if they administered BCG on a regular basis. So again, making sure that we're protecting ourselves from these agents is just as important with BCG as it is with chemotherapy.
Thank you. Clara, I'd like to circle back on something that you said a little bit earlier and was wondering if you can just describe that closed system that you developed for administration of treatment.
Sure. So about 13 years ago, we had a urologist that was moving from a private practice office over to our cancer center and wanted to put BCG in patients in our infusion center. And when I talked to him, he was like, oh, it's so easy. You just put a catheter in, you put a syringe on, you pop out the piston, and you just instill it via gravity. And of course, I was in shock because all I could see was the patient coughing and chemo spilling everywhere. So I looked on the market and there really wasn't much out there closed system-wise to protect the patient or the staff while administering. So I started playing around with the Foley catheter to see if there was a way we could utilize that, which already had to go into the patient, to safely administer chemotherapy. And what we found was if we clamp the IV tubing to the specimen port, clamped off the bag, and raised it above the bladder, we could instill the chemotherapy through the IV catheter into the patient's bladder in a completely closed system. If there was leakage or bladder spasms, we could always unclamp the bag and drop it so that the urine would go back into the bag. But also everything was closed and it went very nice and smoothly, and the nurse was not exposed at all to the chemotherapy. We trialed this obviously on dummies first and then tried it on patients, and we actually had such great success with it. It was a very easy process for the nursing staff and the patients who already needed a catheter in place, and the whole system was closed. So it's worked out great for us. It's been about 14 and a half years now that we've been using the system, and we haven't had any issues with it, any exposure to our patients or our staff. And it is currently put into the ONS chemo safe handling guidelines as a recommendation. And I was very, very honored to be able to publish an article on it back in 2000 and what year was that? 15 about the system. And again, if anyone has any questions on it, they can feel free to reach out to me and I can give them more information.
That's great. Okay. What should institutions include in their intravesicular administration checklist?
So they should include, again, the assessment of the patient before they start treatment. So looking at the urine, making sure that there's no signs of urinary tract infection and no blood in the urine, making sure that the patient voids prior to putting the catheter in, and then making sure the patient is comfortable getting a catheter. Sometimes we can use lidocaine Urojects for the patients to make it more comfortable. The other thing is we need to make sure that the patient can hold the urine for about 2 hours after administration. So there is patient education that needs to take place as well. So that needs to be on the checklist. And then as with any other administration of chemotherapy, we need to make sure that we do all the safety checks of chemotherapy. So the 2 nurse double checks, and those should be included into this checklist. The other thing in the checklist after the administration or the double checking is just making sure that we are clamping the Foley bag and putting it above the bladder, and that we are running the medication in via gravity and not pushing it in, which can cause bladder spasms. And then cleanup is also important, and making sure that we are cleaning up the area and the patient appropriately and protecting ourselves. And then prior to discharge, making sure that we are giving the patient discharge instructions, how to take care of themselves when they get home, and then how long they need to hold the urine.
Okay. So do patients normally have issues with being uncomfortable, during the procedure, or is it usually tolerated pretty well?
Usually the patients tolerate pretty well. They sometimes have bladder spasms, sometimes have a little bit of leakage, so we have to monitor that. Usually you need to slow down the infusion. It is via gravity if the patient experiences bladder spasms. Usually after their first treatment and they feel how it feels, they can hold the medication for the whole 2 hours. And in our institution, the only time we hold them is their first time. After that, we administer the medication and we send them home to hold on to the urine, get up and walk around, and then urinate after the 2 hours. The longer we can leave the chemotherapy in contact with the bladder, the better it is for the patient and the more exposure to the tumor.
What are some policies and procedures that would need to be in place for patients receiving these treatments?
So much like any other chemotherapy, a policy and procedure around administration and disposal is important. And you can add it into your normal chemotherapy policy if you want to, or have a separated policy on intravesicular therapy. The other thing is that there should be some type of education related to this, because it's not a procedure that happens frequently, or not in all infusion centers. Sometimes it's done in OR, so it's done a little bit differently. But again, I think the importance of having some type of policy and procedure around the administration, because it is a specialty administration, is very important.
Exactly. Do you have special educational tools, or are there different types of education that you can give to patients that are getting ready to have this procedure done?
So we do provide chemo care sheets based on the medications they're receiving, and do review with the patient what's going to happen pre-procedure. The nurses do walk through the procedure prior to it happening, the day that it happens. And then we do have great discharge instructions that we give our patient for the self-care after. And the reason that's so important is if the patient is receiving BCG especially, they need to bleach the toilet after use when they're urinating for the first time. And they also have to hold the urine for 1 to 2 hours, depending on the physician, but they like to leave it in as long as possible. So again, we have very detailed discharge instruction sheets telling that patient the self-care that they need to do. The other important thing is with men, as they're urinating, most men like to stand up as they urinate, but when they receive these medications, the first time they void, at least the first time they void, we really recommend for the next 24 hours, but the first time they void, they need to be in a seated position so that it is not splashing all over the toilet seat or the bathroom for other patients, other people to be exposed to.
Gotcha. Thank you for that. What's something about intravesicular chemotherapy that's not often discussed, but you wish people knew more about?
Well, intravesicular itself is not discussed much. There's not a lot of resources out there to look at. When this practice came to us and I did a lit review, there was quite a few old articles. And even more currently, when I did a lit review, there's still only articles written in 2015 are the most current articles you can find on it. So again, just the importance of remembering that these are chemotherapy or immunotherapy or biologic agents that we're giving to patients. So there are special handling precautions that the staff that are administering these need to be aware of. And that it's not something that you can just stick in and run via gravity with an open syringe. And then also that self-care. I think that is always really lacking in patient discharge with intravesicular therapy, especially in urology offices, people that are not used to giving chemotherapy and going through these things, that self-care piece of what they need to do when they leave. My fear is always when I send a patient out after we've instilled that in their bladder and they're driving an hour and a half away from our cancer center, that when they need to go to the bathroom, they stop in a public restroom and go to the bathroom and don't think about all those other people that they're exposing. So again, that education prior to discharge is very important of how to self-care.
Thanks. Do you have any examples of maybe some of the, just like you were saying, with patients who are driving distances for that, what you might tell a patient who would be going back home after the treatment and then having a longer ride? What would your recommendations or your teaching be for that patient at that point?
So first and foremost, we tell them to limit their amount that they're intaking fluid-wise. So we try to really limit the amount of fluids they take prior to infusion and then post-installation, just really because the more you drink, obviously, the more you have to go to the bathroom. If they have a long distance to go, we will a lot of times just have them stick around the cancer center so that they can go in the cancer center and we can take care of it for them. Because again, we don't want them to have to stop on the side of the road and go to the bathroom. It's not like something that you can leave, have a urinal in your car and use, because again, these agents still are active when you urinate. So a lot of times it's just really having conversations with them about how far they have to go. What are they drinking before they go? Is it really in their best interest to leave to go home or kind of stick around the cancer center? And they don't necessarily have to stay in a room, but maybe walk around a little bit and then come back and we can designate a bathroom for them prior to them going home. And then the staff can clean that bathroom.
When they do go home, you mentioned about, a 24-hour kind of time period that you really encourage them that would be the time frame for when the drug would be excreted. So what kind of teaching tools or teaching instructions do you give to patients for at home, especially if there might be children or pets in the home? What kinds of things do you tell them?
So just like with chemotherapy agents, any chemotherapy agent we give, there is that risk of exposure to anyone that's not receiving the chemotherapy agent. So making sure that they sit down when they urinate, that they close the toilet lid when they are flushing, that they wash their hands before and after urinating, and then cleaning up any spills or drips that happen around. We do recommend that they don't have someone that's pregnant or a child help care for them. If that has to happen, we do recommend that they wear gloves, usually double gloves if at all possible, and that they make sure that they're meticulous with their hand washing as well. The patients, as far as feeling, they usually feel pretty well. Sometimes with the BCG, they may get a little bit of a flu-like symptom where they just don't feel very well. But usually the patients tolerate it well, not like chemotherapy where they have nausea or vomiting. They may have some bladder spasms, which we can give them some medication for. But again, it's really just crucial for that first 24 hours, making sure that they are containing their urine into one area and they're cleaning that up. If possible, we always recommend that they use a separate bathroom from someone that's pregnant or a child. It's not always possible, as we know. So again, making sure that they have bleach wipes or Clorox wipes to clean up the toilet after they urinate.
So what resources do you suggest for nurses who want to learn more about this? You mentioned earlier that when you got into this area that there really wasn't very much available to you. So at this point, what would you recommend for nurses who are just, starting to treat patients in this area?
So the ONS communities is a great place to start. I frequently see, about once or twice a year, I see a post come up about intravesicular therapy, and myself and others that are experienced using it do answer those. Like I said, in 2015, I did publish an article in CJON called Minimizing Staff Exposure to Anti-Neoplastic Agents During Intravesicular Therapy. Again, that kind of goes through the steps and gives you some pictures of the system that we've been using. The most current ONS Safe Handling of Hazardous Drugs book does go over safe handling for intravesicular therapy and patient care for that. So that's a great resource. And also in the current chemoimmuno book, there is a small mention of intravesicular therapy as well. So again, the ONS always has great resources, and they try to make sure that they stay up to date with the most current literature that's out there. So I always go to ONS first. I always recommend people go ONS first. There is some literature out there in urology references or journals. Most of it's really geared towards the physicians, not so much the nurses. And the last time I looked, the most current was 2012. And actually, I just looked yesterday, was the most current from them. And they are pretty much the same recommendations that we are using in ONS. So again, ONS always is a great resource to start with.
Excellent. So you've given us a lot of information here today, Clara. Excellent information, and talking about, the different, whether it's safe handling or patient and family education and nursing education with this, as you said, not so commonly talked about treatment in oncology. Are there any final comments that you may have for us today?
I think the final comment I have is if a procedure like this that you don't see very common comes to your infusion center or comes to an area that you are not necessarily used to seeing it, ask the questions, make sure that you do the research. And again, ONS communities is a great place to just reach out to people and see if they are doing these things. And if there's ways that there's people out there that already have something in place for it. I just remember how scared I was when I talked to the urologist for my staff when they said how they were administering this medication. And, I look back at it now, again, it was 13 years ago because my child will be 13 here in a month. And I was pregnant with him when we were doing this. And I was thinking about the safety of my staff and my patients and really just trying to figure out the best way to take care of everyone. So again, if there's any questions that you ever have about the type of procedure or treatment that's happening, really reach out to people out there that have experience in it. And that really does help.
Thank you. I would just want to take a minute and thank you for joining us today and for shedding some light and insight on intravesicular chemotherapy administration and those patients who are receiving that treatment.
Thank you. And again, if you have any further questions, please feel free to reach out to me. You can email me at Beaver, BEAVERC @Karmanos.org. Also, you can find me in the communities under Clara Beaver, and you can send me a message through there. This is something I enjoy talking about, as you can tell. So I'm more than happy to talk with anyone if they have any questions about how to get a program started.
Thank you, Clara.
Thanks.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you download your podcasts. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org.